all today for attending this opportunity for me to speak on palliative care versus hospice care. And I'd like to first start out with the objectives. So the next slide, please, on objectives. Thank you. So first, to review the objectives during today's presentation, I will review the history of palliative care. I'll identify the differences and similarities between hospice and palliative care. I will review the models of palliative care across the United States, and I'll provide an understanding of the benefits and barriers of palliative care from the perspective of patients and providers. And finally, I'll discuss the financial aspects of the palliative care programs. Next slide, please. The history of palliative care. When we realized that hospice and palliative care really began in the 11th century during the Crusades, and then we moved forward to leaders of the hospice movement, which were Saunders and Wald and Kubler-Ross, we look at the Medicare benefit, which was in 1983, but in the early 1980s, the World Health Organization Cancer Unit began the development of a global initiative to really advocate for pain relief and opioid availability worldwide. With this, although at the time of major emphasis was given to cancer pain relief, the management of cancer pain was conceived as really the spearhead for comprehensive and integrated palliative care to be approached in the medium term with all. The first United States hospital-based palliative care program began in the late 1980s, and that was at a handful of institutions such as the Cleveland Clinic and the Medical College of Wisconsin. Since then, there's been a dramatic increase in hospital-based palliative care programs, which are now numbering more than 1,200 across the United States. With that is 81% of the United States hospitals, when they do this data poll, it is only those beds that have, hospitals that have 300 beds or more, and so that's 81%. Next slide, please. So palliative, it is pronounced palliative. We've heard that different ways, palliative, palliative. You'll hear all kinds of noise about how that's pronounced, but it comes from the Latin root of the word palliare, which means to cloak. However, when you're using this term if you want to identify palliative care, and what does that mean, when you're saying that it is cloaking, some people may be believing that you are trying to hide something, that you're trying to hide something from them, rather than really stating that palliative care with that cloak is cloaking the disease from the patient. Palliative care cloaks the patient in an environment of comfort, dignity, compassion, and quality of life. So kind of blankets. I'd rather say blanket than cloak. Palliative care helps to provide the best possible quality of life for patients and their families. Palliative care helps patients and families manage the pain, their symptoms, and the stress of serious illnesses. Palliative care is a partnership of the patient, the medical specialist, and the family. Palliative care is appropriate at any age and at any stage in a serious illness and can be provided along with curative treatment. Palliative care provides an extra layer of support for patients and families with serious illnesses. Next slide, please. So the National Quality Forum and the Centers for Medicare and Medicaid Services, CMS, have actually defined what palliative care is. And palliative care refers to patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. That suffering can be that within that illness is the physical, the intellectual, the emotional, the social, and spiritual needs, and facilitating patient autonomy, access to information, and choice. When we think about years back, that when you would go into a physician's office and get your blood pressure, you'd have to sneak to actually look at what your blood pressure was. Nobody ever told you what that was. So nowadays, in the palliative care realm, we truly do facilitate that patient autonomy and give them that information and access to information, and then choices about that information. I want to really stress that palliative care services are indicated across an entire trajectory of a patient's illness. Its provision should not be restricted only to end-of-life phase. For a long time, hospices didn't want to use the H word anymore, and so they turned as an industry, and we decided that we were going to call it palliative care. However, as we noticed in the 80s, that we truly did kind of separate palliative and hospice. And as an industry, you'll see that it's coming back around to where it's a true separation. What is palliative care and what is hospice care? Next slide, please. So, why palliative? Palliative care addresses the physical, emotional, spiritual, social, and spiritual needs while facilitating, again, like I said, the patient autonomy, access to information, and choice. It promotes the alleviation or at least a reduction of pain and symptom burden, and then increases the quality of life. Palliative care can ensure that all of the above at the same time that the patients are receiving aggressive treatment modalities. Palliative care doesn't interfere with the patient and family goals for curative, or it doesn't interfere with terminal care. Palliative care measures can fill the gap between acute and terminal care. For acute care, the benefits such as Medicare Part A, Medicaid, state funding, insurance, similar to terminal care, although there's this gap in between the payer sources about what is weighed for palliative care. And Medicare A right now doesn't have a palliative care benefit as such in the home care. Next. The World Health Organization's view is that palliative care will enhance the quality of life, that will also positively influence the course of illness, applicable early in the course of illness. And I want to stress again, that's early in the course of illness. Many cancer hospitals now and cancer clinics introduce palliative care at the same time that they're providing the diagnosis to the patient at the very, very beginning of that illness, in conjunction with other therapies that are intended to prolong life, such as the chemotherapy, radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. Next slide, please. So next I want to just talk about the differences and the similarities between hospice and palliative care. Next. Palliative care. This is for people with serious illnesses or injuries who are experiencing pain, uncomfortable disease symptoms, and or disease process stressors that are across the entire trajectory of the patient's illness, and again, should not be restricted to the end-of-life phase. The only requirement for a palliative care consult is a physician's order and the patient's family's permission for the visit. That's it. In hospice, there has to be a terminal illness with less than 6 months to live if the disease runs its normal course. That's certified by the patient's attending physician and also a hospice medical director. So those two need to say that this person has a terminal illness. Now, if the patient does not have an attending physician, the medical director can be the attending physician, so it would only need that one signature. The patient, again, has to elect their hospice benefit, and they have to say that they're foregoing any curative treatments for their hospice diagnosis. So if a patient comes on with a cardiac disease, end-stage cardiac, there would be an attending physician that would give the order for hospice care and say that this patient, based on their prognostication, has 6 months or less to live if the disease of the cardiac disease runs its normal natural course. That would be as a textbook. And then a medical director would second that. And they would say, yes, we've looked at the clinical information, we've looked at the patient's, that we've been presented verbal information or clinical documentation that does say that this patient has this cardiac disease. That will be the end of their life disease. This is what we're going to put on the death certificate. Medicare says that we need to have the one diagnosis. Now there can be multiple that push the disease strength, the disease, but there needs to be one diagnosis. They may still receive Medicare benefits outside of that hospice diagnosis. So if you put the patient on for cardiac and this patient has a fall and breaks their hip, as long as it's not related to that cardiac disease, Medicare still says that they can seek all the curative care they want for this broken hip. However, they should not be seeking aggressive treatment for cardiac. If they do, they need to revoke their hospice benefit. Next slide, please. The hospice and palliative care, now what they do have in similarities is that they both provide a total holistic patient and family-centered care. They both have a goal for alleviation or reduction of any uncomfortable symptom or situation that's affecting the quality of one's life. That can be, again, that social, emotional, intellectual, physical, all of those kind of everything that's wrapped up into a whole person's care that is causing them some kind of uncomfortable situation or symptom. It's hospice and palliative care both are provided by specially trained professionals, and also that we include the patient and the family members into this care. Next. So with hospice, the terminal diagnosis with the 6 months or less to live if the disease runs its normal course, and that's generally a textbook. The patient's attending physician and medical director of the hospice must certify the patient has that 6 months or less to live. And then if the patient, again, has no primary care physician, the medical director can certify the patient as terminally ill, and there's no need for a second physician to certify. We have many patients that don't have an attending. And then the last is that the patient has to elect their hospice benefit. They're waiving their Medicare and Medicaid benefit for the disease that brought them onto service. So when they elect that, they have informed consent, they understand the philosophy of hospice, they understand what the plan of care for them will be, and they're saying that, yes, this is something that I want to do. I've made an informed decision. I've had informed consent, and I am electing this Medicare benefit that I've worked for all of my life. Next. So the Centers for Medicare and Medicaid Services, CMS, they've developed some guidelines for establishing a 6-month prognosis for several non-cancer terminal diagnoses. We know that physicians don't have a crystal ball. We know that the hospice personnel don't have, visual of what this is going to be exactly. But there are some guidelines that CMS has developed. Through those guidelines, they're based on normal disease progressions. So when we're saying that the disease is running its normal course, again, we're saying that this is what textbook, this is what research, this is what CMS has guided us to say that these are specific indicators that would prognosticate that this person has, best option for us on our prognostication is that they do have 6 months or less. The patient or their surrogate agree that the course of treatment for the patient will be comfort and palliative in nature and will no longer seek aggressive curative treatment for that disease process, which we know that there's no cure for Alzheimer's. There's no cure for a heart that no longer can beat as it should. There's no cure for sometimes that the end-stage cancers, that there are no cures anyway. But the patient is electing that they're not going to seek any aggressive treatment. We always tell people that if there's something new comes out tomorrow, they have the right to revoke their hospice benefit and go for that cure. But while they're under the hospice benefit, they won't be seeking that cure. Next slide, please. So what does hospice benefit include? It includes nursing, home health aid, counseling visits to address those physical, personal, emotional, spiritual needs. We provide the medical equipment based on that disease process. If they need a walker, they need a wheelchair, if they need a hospital bed, if they need an oxygen concentrator, if they need nebulizer machines, those kind of things, sometimes a Hoyer lift, all of those are incorporated into that hospice benefit. We pay for the medications that are related to the terminal illness. That means that if this patient had cardiac, that we would be paying for the cardiac medications. We would be paying for pain medications, and Medicare is getting ready to, disseminate whether or not that hospice should be paying for all medications. But at this moment, medications just related to the terminal illnesses are what we paid for. Bereavement services for the family at least 1 year. So we know that when the patient expires on hospice services, Medicare no longer pays us a per diem, but the Medicare benefit says, you know what, we paid you up front for what we need for you to take care of their family member for at least 1 year. The social workers, the spiritual counselors, and the nurse will identify through that patient's experience with hospice who is the person that needs to be with the bereaved. It can be only one, it can be four, it can be whoever that they believe that needs those bereavement services, that we keep them in that blanket of care throughout their at least a year. If they need longer than a year, some people have been on bereavement services for 2, 3, 5 years for complicated grief, and that we have bereavement groups and everything that we continue with that patient's family. The hospice provides 4 levels of care. So in that Medicare hospice benefit are 4 levels of care. The first one is routine home care. That is where the patient's in their home, group home, assisted living, nursing home, and we've designed a plan of care. And that may be that the nurse is going to visit 2 to 3 times a week. Nurse's aide is going to visit 2 times a week to do their grooming. There's going to be a spiritual care counselor that may visit with them 1 or 2 times a month, whatever the family and the patient decide upon. And then a social worker will make their visits. There's also volunteers that kind of get together and, again, manage the disease and everything that surrounds that disease process. The next is respite care, and respite care are for those patients that are living at home. They have a caregiver, and this caregiver has been up and down with them throughout the nights, throughout the weeks, and they need a rest. So the respite care is for caregiver relief, and it's paid by Medicare for up to 5 days. That 5 days can be in somewhere where the hospice has a contract with. So it could be in an inpatient unit, it could be in a facility. It just depends, and it's, of course, by patient choice where they want to go. The next level of care is inpatient, and it's called general inpatient care, GIP. So for that, it depends on the patient. So respite is for the caregiver. The inpatient is on the patient. And that patient is having something that is a symptom that it cannot be managed at home. So that could be that they're having difficulty with breathing, that the medications that we've had in the home are not helping them at this particular point, and they need a higher level of care. It can be that the pain and symptoms of the disease cannot be controlled at home, and they need to be in a general inpatient unit. And so where they may have the expertise of the nurses, probably more like IVs, subcutaneous medications, that they are at, again, like a higher level of care. I always connect that to say if you were in the hospital and you go, all of a sudden you go into an ICU, this is kind of that differentials in the level of care from routine to inpatient. Then there's continuous care. Continuous care has the same kind of identifiers as a general inpatient. So if you had symptoms that are out of control, pain that's out of control, intractable nausea, vomiting, difficulty in respirations, those kind of things that need a skilled nurse to do some kind of interventions on a very, usually at least every 30 minutes to an hour that we're doing something for the patient, that continuous care can be provided in the home setting. But again, it has to be with that expertise. Continuous care by Medicare benefits has to be 51% of the time has to be a skilled nurse, and that 49% of that time needs to be, can be like a nurse's aide. Spiritual care counselors, social workers' hours, even though they visit, can't be counted into that kind of matrix or that ratios. Respite and inpatient levels of care can be provided in the hospital and the hospice's own general inpatient unit or a skilled nursing facility where that hospice has a written agreement. Next slide. When the patient elects the hospice benefit, again, they waive all rights to the Medicare payments or services related to that treatment of the terminal condition by healthcare providers other than their hospice or attending physician. So they are saying that now I'm not going to go to this neurologist, or I'm not going to go to this, dermatologist. I'm not going to go see all of these other folks. I'm going to have the pain and symptoms or any discomfort. I'm going to have that kind of taken care of by the attending physician and the medical director. Now, that doesn't mean that they're locked into this. The hospice can facilitate and have a contract with perhaps that neurologist or that dermatologist, and that we kind of are their gatekeepers for the Medicare monies. but that we need to know that up front. Hospice patients can be hospitalized and continue to receive their medical care from healthcare providers other than the hospice and attending physician for illnesses unrelated to the terminal diagnosis. Again, like that cardiac patient that has the broken hip. Hospice patients can continue to receive Medicare room and board benefits in a nursing home for conditions that are not related to the terminal diagnosis. Next slide. Hospice patients can continue to receive home health benefits for conditions that are not related to terminal diagnosis. That's a Medicare regulation. However, there are some home health agencies that don't quite believe this, so it does determine on the hospice kind of facilitating with the home health that we can work this out. Hospice patients can revoke their hospice benefit at any time. So you could have that person elect their hospice benefits. Somebody comes in from the family from, we used to say California when I was in the Midwest, but I'm in the West now. So let's say they come in from the Midwest, and they're saying, you know what, we don't want mom on hospice. What they can do is they just revoke their hospice benefit at any time. Their Medicare benefits begin again for that diagnosis. Everything goes again like they were. And let's say in a month they decide, you know what, hospice was a good idea, and we want hospice to come back in, they can sign back up. So it's not something that if you don't use it, you lose it, or if you have it, you can't get rid of. So it is one of those that you can pretty much yo-yo if you need to. So again, they can elect their benefit and they can revoke their benefit. According to the Patient Self-Determination Act that was passed on November 5th, 1990, Medicare hospice providers are prohibited from discriminating against a patient who does not have a DNR order. So it used to be that back in the early days that if they were to come on hospice, they had to sign that they no longer were going to have any kind of cardiac compressions or resuscitations of any kind. But now, 1990, they said, no, if you want to die of that cardiac arrest rather than you want to die of your cancer diagnosis, you can make that dissemination. Next slide, please. Hospice Programs. A hospice is a public agency or private organization that is primarily engaged in providing care to terminally ill individuals. Now, the reason that this is important because it's primarily engaged in providing care to terminally ill individuals. We'll talk about how hospices do palliative care a little bit later. Hospice care provided by hospice must meet Medicare conditions of participation. What that means is we have regulations and rules, and we need to participate in those rules and regs, or we cannot accept Medicare monies. Hospice care must be provided by following the plan of care, and that plan of care is actually developed for the patient and their family caregivers. Palliative care refers to patient and family-centered care that optimizes the quality of life by anticipating, preventing, and treating suffering. Palliative care continuum of illness involves addressing physical, intellectual, emotional, social, spiritual needs, and facilitating patient autonomy, access to information and choice. Palliative care services are indicated again across the entire trajectory of the patient's illness, and its provision should not be restricted to end of life. Next. The philosophy of palliative care is that total patient-centered care for patients with serious illness, chronic illness, or terminal illness. That can also include an injury. It integrates the physical, emotional, social, spiritual aspects of patient care. Palliative care may include and involve the patient's caregivers, relatives, or loved ones when a patient chooses, and it simultaneously, patients can seek curative treatments while receiving comfort care. Next. Models of palliative care. So we want to talk about models, the different models of palliative care across the United States. There are inpatient units, and that's the inpatient setting. These include an acute or rehab hospital, freestanding hospices, palliative care units. Palliative care team members provide visits to patients and families. That's actual face-to-face visits in these settings. There are some consultation teams. Those include visits, face-to-face, from palliative care physician or nurse practitioner who are trained, certified hospice and palliative care RNs, social workers, and spiritual care workers. There's outpatient settings. These include visits from the palliative care teams in settings such as home, clinics, physician offices, nursing homes, home health agencies, assisted living residents, and group homes. As you can tell, palliative care can be at any place. And then there's the model that includes phone calls and or visits. So you can have a palliative care program that are only phone calls that are from specialty trained team members as scheduled by both parties, the family and the patient and the program. And these are usually provided by a hospice program. So you can have a visit where you send out a palliative nurse. You can have a visit that could just be a phone call, and you're just checking on the patient, asking them about their levels of breathing difficulty, pain, any kind of, if they're having any kind of economic, social, spiritual, any kind of discomfort. And so the palliative care team of individuals will help put that all in place for that, another support for that patient and their family. Next slide, please. So there's 4 primary models that are utilized in progressive United States skilled nursing homes. So skilled nursing facilities. So these are where they accept Medicare A. They have usually they have RNs that are at least through the day. They have nursing services that are throughout the night, and they are licensed as a skilled nursing facility. A recent report developed by Centers to Advance Palliative Care, CAPC, revealed 4 primary models that were utilized in progressive United States skilled nursing homes. However, most skilled nursing facilities still do not have a formal palliative care service. So the first one would be palliative care consultation services. Those are for palliative care providers who are not employed by the nursing home. They provide and bill for consultative services to residents as requested by the nursing home medical director or the patient's attending physician or the nursing home director of nursing. Now, if they're going to bill for their services, we'll get into this a little bit later, they have to have a physician in order for the patient to receive those palliative care services. The second one is hospital-based palliative care consultation services. Those are professional staff that's employed by the local hospice that can provide non-hospice palliative care consultative services as requested by the nursing home, again, medical director, the patient's attending physician, or the nursing home director of nursing. Next. Next slide, please. There you go. The third is the nursing home services integrated palliative care. So many nursing homes have embraced the qualitative initiatives such as pain and symptom management, and they actually integrate palliative care philosophies into their culture of care. And then hospice care. So hospice-eligible nursing home residents receive the specialized end-of-life palliative care services from contracted hospice providers. Next slide, please. So physician subspecialty of hospice and palliative care medicine was only initiated in 2006. Before that, there was no subspecialty of hospice and palliative care medicine. Although we know that hospice has been since 1983, now we have in 2006 that it was actually recognized that it was a subspecialty. The practice is to provide expertise in the care of patients with life-limiting and or catastrophic injuries, the relief of distressing symptoms, the coordination of interdisciplinary patient family-centered care in diverse situations. The use of specialized care systems include hospice, management of imminently dying patients, and then legal and ethical decision-making in end-of-life care. The United Kingdom, on the other side, has had physician subspecialty of hospice and palliative care since 1989. So we're a little bit behind. Next slide, please. The number of palliative care and hospice programs has grown rapidly in recent years, and as a result, recognition of these unique set of skills that are required to manage these symptoms and needs of seriously sick patients, including those terminally ill and the growth in the population living with these chronic, debilitating diseases. Although the provision of this specialized care occurs at all levels of the healthcare system, it frequently requires the input of specialized teams. Next slide. So now let's talk about the benefits and the barriers of hospice and palliative care from the perspective of the patients and their providers. Next slide. So what are the benefits of palliative care and hospice care? So the first one that we think of is pain and symptom burden relief. There's actually been studies that have increased the length of life with quality of life. So when somebody was on palliative or hospice care, there was a study that was conducted that patients that had hospice or palliative care, actually their life was extended. So because if you know that pain, suffering would diminish, how they're eating, how their activity would be. Once you get that pain and symptoms under control, the person has a better quality of life. They have family satisfaction scores have increased. Difficult patients can become less difficult, so family members as well. So if you have someone who has, my goodness, if you have pain that's out of control, you're going to be a little difficult to deal with, even with your own family members. Some people don't want to have anything to do with that, people coming over to socialize because they're in such pain. So once that you get that pain under control, those symptoms under control, you actually have, again, better quality of life, and maybe you're not so difficult anymore. The cost of care decreases. There's been studies that prove that. The quality of life prevails. You have, again, physical, social, psychosocial, emotional enhancements of life. You have a combination of a pharmacological and non-pharmacological modalities. So the people that provide the palliative and hospice care, again, have expertise in how to manage these modalities, whether that's with medications or non-medications, such as therapeutic touch, music therapy, pet therapy. There's all kinds of different non-pharmacological modalities. We have increased patient communication. We have setting of clear goals and patient understandings. We have hospice, again, that pays for medications, the durable medical equipment, meaning the oxygen, the hospital bed, supplies if someone has a wound. It's related to their terminal diagnosis because they don't, let's say an Alzheimer's patient doesn't know how to turn anymore because they don't have the cognition in order to make those turns in the bed, or they don't have the physicality of being able to move, and they develop a wound. That is directly related to that terminal illness. So the hospice pays for wound care supplies, pays for the nurse to come out and provide that wound changes, and then pays for the pain medication that we would be giving before the wound care. We provide certified home health assistance, nursing visits, social workers, spiritual care counselors who are trained, again, in end-of-life and palliative care, and provides the additional oversight of hospice medical director for the terminal illness and all related conditions. Next slide, please. Hospice and palliative care certified physicians have this special knowledge, and they have the skills to prevent and relieve the suffering experienced by patients with life-limiting illnesses. This specialist works with the interdisciplinary hospice or the palliative care team to maximize quality of life while addressing those physical, psychosocial, and spiritual needs of both the patient and the family. Palliative care services provided in the hospital, intensive care unit settings, provides focused support for patients and their families in managing end-of-life conditions, assists with end-of-life decision-making by coordinating a facility family members, consultation with patients regarding their desires for care. So you have a patient who's on a ventilator, has been on a ventilator for, many hospitals have, if you're on the ventilator for 7 days, if you're on for 5 days, the next step in their protocol would be whether or not that they were going to do a tracheostomy or whether they're going to do a PEG tube for feedings, outside of the stomach feedings. And so there's a way that the palliative care teams can approach this very, very significant decision-making process for the family, can actually explain what the ventilator does, what the tracheostomy would mean, what does a PEG tube feeding mean? And so having those discussions is actually the way that palliative care services can help with end-of-life decision-making, or whether they want to take the ventilator off and allow the patient to die naturally. Sometimes the patient continues even after ventilator removal, or that they talk to them about what their trajectory of the disease will be with a PEG and with a trach. So next slide, please. The emergence of palliative care as a specialty in the United States is a mean of tackling the perfect storm of all issues of quality care. Affordability, we talk about economic restraints. We talk about quality of life rather than sometimes quantity of life. We talk to the patient about the palliative care is poised to become universally accepted. We want it to be universally available, and we want it to be a modality that healthcare addresses both needs of the patient and families who are experiencing these serious, progressive, and life-threatening illnesses, and also on the cost of delivering such needed services. Next slide, please. So with severe pain, studies have proven that it's highly prevalent, with rates of 40 to 70% in patients with advanced cancer, liver, heart failure, HIV, and renal failure. Evidence from these multiple studies proved the use of rehabilitative therapy, clinical care pathways, and care management pathways to improve pain management in palliative care can model ways of how healthcare systems can be changed to provide adequate and continuing pain management in palliative care. You wouldn't believe how many times that we see that the patient may only be on Tylenol, or the patient would be on even such thing as just one Motrin, and they have multiple issues with cancer pain. So I think with palliative care and hospice care integrating into the healthcare systems, we have actually produced better health care on pain management. The result of a 2010 study in the New England Journal of Medicine showed that lung cancer patients receiving early palliative care experienced less depression, increased quality of life, and survived 2.7 months longer than those receiving standard oncologic care. Next slide, please. Research shows that the conventional medical system often fails to provide sufficient education and counseling on relevant topics such as palliative care. No one really wants to broach that subject. Their physicians have not, a lot of times, been trained in how to approach this significant and very gentle situation of palliative care or hospice care. And patients on palliative care programs who were discharged from hospitals alive had an adjusted net savings of $1,696 in direct costs per admission versus an adjusted net savings of $4,908 in direct costs per admissions for those palliative care patients who expired. So you can see the difference and see how we have actually saved Medicare, insurance, state funding, resources on healthcare. Next slide, please. So comparing quality of life before and after a designation to a palliative home care team in patients with different cancer diagnoses, an assessment of the quality of life at end of life was conducted by this study. The patient's quality of life improved in physical, psychological, medical, and global areas after designation to palliative care teams in the home. 6 items significantly improved: the hours recumbent during a day, nausea, anxiety, getting a hold of staff, received care, and global quality of life. So decreased depression, low in mood, pain, and meaningfulness was associated to global quality of life. Next slide, please. 10 to 12% of the total U.S. healthcare budget and 27% of Medicare annual budget were spent on end of life, at the end of life. In the last year of a patient's life, this patient will average 1.7 admissions to a hospital with an average number of hospital days of 18.3. Even 30 days before a hospice admission, patients average 12 days in a hospital. Research published in the Journal of Pain and Symptom Management found that terminally ill patients who received hospice care lived on average 29 days longer than those who did not opt for hospice near the end of life. Next slide, please. So the financial aspects of palliative care programs, the federal government estimates that the United States population aged 85 and over will grow from 5.3 million in 2006 to nearly 21 million by the year 2050. 68% of Medicare dollars are spent on addressing the needs of Medicare patients with greater than 4 chronic conditions, and 5% of Medicare enrollees with the most serious illnesses account for over 43% of Medicare expenditures, with the top 25% of enrollees accounting for 85% of the cost. That in and of itself is dramatic. So just that statement of 68% of Medicare dollars spent on addressing the needs of Medicare patients with greater than 4 chronic conditions. So that could be COPD, which is congestive chronic obstructive pulmonary disease, which then in turn usually produces congestive heart failure. Then of those, we have a lot of patients that are activity bound. So they may have a catheter, they may have a chronic urinary tract infection, they may have lots of different things that one disease kind of trajects onto the next and to the next and to the next. And you can see that this is why the Medicare dollars from these studies, Congressional Budget Office in 2005, are showing that these needs of these patients are taking the most of the Medicare dollars. Next slide, please. The financial aspects of palliative care programs, this is continued, that Morrison et al. 2011 found that palliative care programs in a 400-bed hospital would have a cost savings of over $1.3 million per year. Palliative care, in addition to hospice care services, have proven to reduce hospital readmissions within a 30-day window. In a 30-day window, they're reevaluating, Medicare is reevaluating if someone is discharged from the hospital, whether or not that patient comes back within 30 days. The consulting palliative care physicians and nurse practitioners in hospital settings can do a consultation, which is an inpatient consultation, and the CPT codes that they use are 99251 and 99255.